Listening to podcast is no replacement.
Here we go.
Listening to podcast is no replacement for real training. While we attempt to provide accurate commentary, we hold no responsibility on how you use the information we provide. Get medical training. In the blink of an eye, everyday order can be replaced with once-in-a-lifetime chaos. Be prepared. This is the Civilian Medical Podcast.
Welcome to episode 10. This is Sean Heron. With me, as always, is Skinny Medic. Diedrich, how you doing today, man?
Good. How are you, sir?
I'm doing wonderful. It's one of those days where you kind of like wake up a little bit late and then you lounge just a little bit longer than you wanted to, and then everything happens and now you're suddenly running late. That's me.
It sounds like my life.
I'm glad I'm not the only one.
Like it sounds like my week. It sounds like my life. I feel like I'm always running behind.
I know, man. Me too. I'm really excited about today's episode just because it's outside my wheelhouse, and I'm really looking forward to learning along with the listeners here. You are going to be the man today. You're going to share with us a lot of stuff about fractures.
Yeah, I'm excited about this. This is something that's a little bit different. We kind of went through the March algorithm in the first few episodes. And then, we talked about medical, which was, kind of definitely some things people can operate on a day-to-day basis. And now I think fractures. I mean, this is something that could happen while you're grilling. Kids are playing outside, they're riding a bicycle. So this is definitely something that could happen going into the summer months here. So I definitely think that's something that's very useful.
What's the danger of fractures?
What'd you say? Sorry.
What's the danger of fractures?
So there's some fractures that can cause bleeding internally with, like your femur fracture. Those can hold a lot of blood on the inside. Pain is obviously it's a big deal. And then talking about infection, long-term stuff like that. So there are some dangers that can go on with that. If you get some major swelling, if you get just a really nasty fracture, you could lose pulse motor sensory in the extremity, which is basically like you have a tourniquet on now. So that same hour time frame that we talked about before with tourniquets, that kind of goes into effect here. So a little bit dangerous. They're not super, life-threatening typically, but there are some things we need to look out for.
All right, cool. Well, let's start at the beginning.
Yeah, so I think you kind of open it up and say, fractures are, there's a difference between a fracture and dislocation. Are you there?
Yeah, can you hear me? Can you hear me?
Yep, but my video is frozen for you. I'm going to cut my video off.
Okay, cool.
It was like really quiet too, and I was like, I don't know, something's wrong.
No, I'm here.
Okay. How's that? Is that better?
Is that better for you?
Yeah, sorry about
No
that.
problem.
We can edit that out, I guess. But
Yeah, totally. It's easy.
Yeah, so I'll start whenever you're ready.
Right now.
Okay, so I wanted to talk about like the difference between a fracture and dislocation. A lot of times, just people get it kind of confused and things like that. So a fracture is going to be where a bone breaks or twists or something happens with the actual bone, and a dislocation is for a joint. Like a shoulder, a knee, an elbow. Obviously, those can combine injuries, and you could have a dislocated elbow and a fractured arm. But there are differences in there, and kind of hard sometimes to see if it is a bone, especially if it's a fracture close to the hip or the knee, something like that, without doing an X-ray. And we don't have X-ray vision. They haven't made that for the iPhone either yet. So kind of waiting on that one.
It's coming.
It's coming. That'd be awesome. I looked at a portable ultrasound yesterday that hooks up to the iPhone. So I'm super excited about that. But so definitely we need to kind of stabilize these patients, how to make them comfortable as best we can, and either we're going to wait for EMS to get there or we're going to transport them to the hospital ourselves.
All right, makes sense.
And then the other thing is kind of we can talk about fractures is difference between open and closed, and this is pretty self-explanatory. But if you have an open fracture, this is going to be where the bone has fractured and come through the skin, has broke the skin. There can be some bleeding occurs with this. Infection is going to be a big risk for this. And then if there is major bleeding, we just don't want to put a tourniquet over top of the fracture. You want to go well above the injury. And then a closed one is, it's the bone's broken, whatever happened, but the skin is still intact. So just kind of looking at those are kind of big groups of differences between fractures open and closed. And it's kind of things we look at first as first responders is to see if it's open or closed, because I may need to put some bandaging over top of it to kind of either control the minor bleeding or just kind of prevent infection.
Yeah. Now that there was a motorcycle video we talked about in a previous, there was two casualties in the street, and they were broken in all the different ways. They had open, closed, all kinds of fractures. It was crazy, and that was like everything they had pretty much was fractured.
Definitely. I mean, that video there was pretty extreme. Like, it had a lot going on. But yeah, that guy was a perfect example. And you can see like the bone is like usually it's a really pretty white. Like, I know that sounds pretty sick, but it is. It's a really like bright white typically. So you can see it very well when it starts to come through the skin. And the bone, when it fragments, especially in adults, is super strong. It's getting tight already. And then so when it comes through, it's actually can be a little sharp. So if you're dealing with it, it's already cut through the skin. So if you're trying to bandage it, just be aware that it may be a little sharp, have some sharp edges on it.
Yeah, for sure. So there's lots of different kinds of fractures, and I'm sure that sometimes it'll be tough to tell exactly what they are if they're closed fractures and things like that. But what are all the different types?
Yeah, so like I put these in the show notes, and just kind of like you're not going to be diagnosing these types of fractures in the field. I don't diagnose them in the field. I'm like, oh, that looks really jacked up. Your knee's not supposed to be going that way, or your foot. You're not supposed to have an extra elbow in the middle of your arm. And that's basically why that's my diagnosis in the field. I'm like, they had an extra elbow between the wrist and their real elbow, and we splintered it. But I thought we could give a little bit of information here just to kind of help educate the people, guys and gals that listen to our podcast. And so the first one I wrote down is green sticks, and these are typically like for children, like because their bones are still flexible somewhat. I mean, for a small child, an infant, to break an arm, it takes a lot of force because they will still their bones will bend and they'll flex. So if I see a child that has a broken arm, broken leg, you automatically think about the mechanism they went through. How much force did it take to actually break their lower leg or their upper arm? It takes a lot of force because they will bend. They are flexible there.
Yeah, and it's like if you've ever broken an aspen twig, like it doesn't kind of break, but it kind of opens up in the middle and just like flays out a bit like that. Is that kind of what the green
It
stick?
is. Yeah,
Okay.
exactly.
Ugh, awful. So you know how you don't like it's vomiting, right?
Yes, vomiting.
For me, it's this stuff. This stuff makes me cringe. If you guys could see the video of my face right now, I have had that just the entire time we're talking about it.
So one of my first partners I had in EMS, she absolutely hated fractures. And of course, I did not like OB, like pregnancy, psych calls, none of that stuff. So we had a deal that I would run every fracture, no matter what it was, and that she would run all the OB, psych, crazy women. And that's the way our jobs went for a long time. We were partners for a long time. So I would just run the nasty trauma stuff and fractures, and she would run every OB call or every crazy woman who was hysterical crying. She would run it. So it was a great partnership.
I love it. I love it. All right. So green stick made me cringe. What's next?
So transverse, this is where the break is straight line right across the bone. It's a smooth break, pops it right out. And it's a clean break. You can see it on x-ray. This is going to be more for like teenagers, that older adults where the bone has gotten stronger, but it breaks like a board, just snaps right in half. And I think about this one, like I remember he pulled up an EMS and his kid's waving at us like, "Hey guys, I'm over here," and he fell off a trampoline and he had that extra elbow in his wrist, like it's like his arm is doing the wave literally as he swings his arm around. So that was probably like I would think a transverse break. Another one we can see is it's called a spiral, and this is where you see this a lot. Like I think about football or soccer players. They get kicked and they're running and it's actually a twisting motion. So like the lower legs are really bad. I think about doing this, you'll just see like a twisting injury and the tib fib will just rotate around and break.
That one's tough. So I actually worked with a guy, and him and another guy were arm wrestling at the office one day, and he got a spiral fracture of the arm bones. I don't even remember if it was upper or lower. But it took him forever to heal. He was in a cast and had multiple surgeries, and it just took forever to heal.
Those are nasty. I mean, you get a lot of like muscle damage, ligament. I mean, those are a big deal. So those can be nasty for recovery, doing physical therapy, whatever, maybe afterwards. Those are a big deal.
Yeah, definitely. He was in an extreme amount of pain.
And then we talked about the transverse was just straight across. The oblique ones are kind of a diagonal. Just obviously we're not going to diagnose that in the field, just kind of how the break occurs. The other major one we see a lot is the compression fractures. And this is just where the bone is crushed because there's flattening against a flat surface and they just can't handle it. Maybe this is kind of an example of like someone who's elderly and their bone density just isn't what it should be anymore, and they fall. And a lot of times they will try to use their hands to catch themselves. And when they do, their force of their body lands on the ground with their arms straight out, and you'll see like that energy has to go somewhere. So it's going to want to go through the bones. And a lot of times their bone density, as we get older, just isn't what it was. And you'll see those types of breaks as well.
Yeah. Now I've done a splint on live tissue, and I don't know what's going on right now, but my face is just wrinkled up this entire conversation. Like thinking about every single one of these scenarios, just like, no, I don't want to see it.
They are typically just, we call them distracting injuries. And that's one thing I talk about in my class. After you've went through the part of the March algorithm where you fixed everything, you can kind of focus now on those distracting injuries. You may have a guy who's gotten hit by a car and his leg is rotated 90 degrees, his foot sticking up the wrong way, but that's a distracting injury for you. He is not going to die immediately from that. He's going to die immediately from the bleeding from his arm or whatever. So you can't get distracted by that. So we typically call all of these distracting injuries because they'll distract you. They look nasty. They look like, oh my gosh, but they're not life-threatening.
Yeah. But blood loss can be a big deal, a big concern with these though, right?
They are. So a couple of places where they are a big deal is like a femur fracture. I mean, you can hold almost 1,500 cc's or 1,500 mLs, depending on what system you're using there for measuring. That's a lot of fluid, especially if somebody get like bilateral femur fractures. They've been in a major car wreck, they came up and now their legs are fractured. That's a lot of fluid that can be contained inside the thigh area. And even like the lower leg can hold up to 1,000 cc's of blood. So you get someone with some multiple leg fractures going on that has cut a major artery, or there's a lot of bleeding that can occur, even into the pelvis too. An open fracture pelvis. I mean, when I say open fracture, I mean it's like a book. So the pelvis normally stays closed and it fractures open. So it's called a bookcase fracture. It opens up the pelvis, kind of fillets it open like you would like fillet like a chicken. If you're chicken breast, if that makes sense. Trying to describe this over a podcast is interesting. It adds a new words are important.
Exactly.
So it opens up, and there can be a lot of bleeding inside the pelvis. So there's a lot of talk about using pelvic binders. We'll talk about that in a few minutes. Trying to close that pelvis back together, kind of help control bleeding.
Makes a lot of sense. All right, so we've talked a little bit about what they are and kind of what they look like on the inside and what some of the things that can happen can be. But how do we even take care of this stuff?
So I thought we just kind of start from the top and work our way down, and kind of how to help people walk around. And you got to get creative with these sometimes. I mean, sometimes you may not have the exact material that you need, so you kind of have to get creative with what you're using. But so we'll start with fingers. Fingers are easy. You just tape them together. You can put some padding in between them because a lot of times they may rub and blister up, but you have something beside each finger, hopefully, that you can use to tape it to help hold it stable. And that's really what you're looking for is to try to, movement is going to hurt the patient. Movement can cause further damage inside. So if you can keep the arm, leg, or whatever you're splinting still, then that's going to help your patient be more comfortable.
All right, that makes sense. So tape and then padding in between if you need to.
Correct.
All right, what's next?
So we talk about like the clavicle, which is the shoulder area. That's a good one to get popped, especially for like sports injuries, things like that. That's a sling and swab, which is something that you will learn in a basic first aid class. You've learned in Boy Scouts. That's just making a basic sling. You can use the triangle bandages. You can use sheets. But you're just making a sling for them. Typically, I will hold the triangle up, tie a knot in the top of it, and that's my pocket for where the elbow goes in. and you take one of the other ends and you go under the arm, you go to the unaffected side, you go under unaffected side. Hope that kind of rhymes, kind of makes sense there. And then the other one goes over top. Tie it behind their neck. Maybe put some little padding behind there, so it kind of doesn't pull on the neck too much, and it's gonna help stabilize that area for them.
And that's the thing, is any kind of movement of that arm at all is going to be extremely painful. I've heard that those injuries are just ridiculously painful.
Yes, and depending on how how extensive the damage is, they may need surgery. So it's not something that's going to heal very well on its own. That you may actually have to go to surgery for that.
Yeah, that makes sense. Okay, next.
So arms, there again, this is something else that's a common, especially elderly patients. Besides like hip, probably next will be hip for elderly patients. But arms, if we think about that lower arm, the radius ulna area is the area between the wrist and the elbow. You kind of have to use some kind of rigid splint. This could be a board. This could be newspapers. Sticks, just don't use anything really pointy like briars. No, that's bad. But you want to be able to control the wrist and the elbow when you put this splint on. That's important because if you don't control both joints before and afterwards, you're not really making a splint here for the best part. So, kind of put the arm in whatever splint you're going to use, but make sure it controls the wrist and the elbow, and put it in a natural position. If you put the wrist all jacked up at like a 90-degree angle upwards, that's going to get very painful very quickly. So try to make the wrist, in a natural position, support the wrist, support the elbow, and you could use, a cardboard, whatever you want to. Use some cling duct tape and wrap it to help hold it in place.
When you say controls, you just so clearly keep them at natural angles, but you said control the elbow and control the wrist. What do you mean specifically by that?
So you don't want the wrist to be able to be bent. You don't want the elbow to be bent. So, if I'm doing like a lower arm fracture, I will put a board down, maybe like a cardboard splint, something like that, to control, to help go between the wrist and the elbow. And then we'll put them in a sling, because now with that board going up under the wrist, they can't bend their wrist. If I put a sling on them as well, now I've controlled the elbow. It means they can't really move their elbow very much without forcibly moving it. So it helps support all those joints that are in limbo right now.
Okay, that makes a lot of sense. So that's lower bones. What about a fracture of the upper bone?
So there again, you could do a board up from the shoulder to the elbow if you'd like to. Make it kind of bend around the elbow, and then put a sling on them as well. So that sling really it's one way of splinting that controls a lot of the upper body. And I show it in my class, and we teach on it a good bit, because it's kind of difficult if you've never done it before, but it does control the whole upper arm. So if you can, wrap the board around between the shoulder and the elbow, and then put a sling, you've controlled that humerus bone.
Mm-hmm. All right, good stuff. Now, in the notes it says ribs are next.
Yes.
And another extremely painful thing.
Yes, and unfortunately, there ain't a dang thing we can do about it. You can't like put a board on someone's ribs. There's not a lot you can do for it. So bulky dressing, a pillowcase, something to kind of help hold in place as they breathe. They take a deep breath, because breathing is going to be painful for these patients. So even something like a pillowcase, a sheet, something they can hold against them to kind of help stabilize it as as they take a deep breath. And the muscles around here will start swelling. So even in the arm or wherever fracture we're at, the body's automatically going to start swelling around that. It kind of helps splint it in place. So you're going to get some swelling around the chest cavity area, and the body's going to try to hold those ribs in place. Typically, if you just get one rib that's fractured, it's not a big deal. They don't even really do surgery for that. They don't do pain meds anymore because of all the stuff going on with that now. Mm-hmm. They will just give you basically a sheet, a blanket, and tell you, good luck. And one of the fears, there's a couple of things we can look at for rib fractures is pneumonia, especially in older population. They can't cough, they can't clear their lungs out, so they are very prone to get pneumonia after a rib fracture. So we kind of have to keep an eye on that. And then if it's two or more fractures together, it means like the ribs are side by side and there's two or more broken together, that's actually considered a flail segment.
Yeah, and that's another dangerous thing.
that is dangerous. So we do need to take a look at this, open up their shirts. Obviously, privacy would be a concern here. But taking a look at that and just make sure that this is not a flail segment. That you see like a section of the ribs moving. You'll see it completely separate from the rib cage as they breathe in, and then it bulges out. It's pretty obvious that they have a flail segment, and these patients are going to be short of breath, unable to breathe. So you're going to understand, hopefully, by doing a good assessment, that this is an emergency situation.
Yeah. And again, that flail, it's when the rib breaks in two places. So it's completely detached from that chest wall area. And yeah, that I can't even imagine how bad that hurts.
No, like I cannot. That's not the best thing in the world. That's gonna feel pretty painful.
But really, ribs, not much we can do.
Not much. Just the bulky dressing. I mean, like I've seen some people talk about like doing Israeli pressure bandage, but you have to be careful doing like wrapping something around someone's entire chest, because if you wrap it too tight, now their chest can't expand out to what it needs to, and you're going to impede their breathing. And so you just have to be careful. So typically, if I'm going to tape some bulky dressing, maybe I'm using like a multi-trauma dressing, I may tape it on there and then I help them hold in place, but I don't tape all the way around their chest. I just tape like a section off.
Yeah. And any displaced fractures, I mean, it's going to be extremely painful if you kind of wrap pressure around that and then it moves that into some tissue or something. It's that's definitely stay away from kind of really wrapping stuff all the way around.
Yep, exactly.
All right. Hips and pelvis.
So hips and pelvis, this is there again. We're probably not going to know if this is what kind of fracture it is, but one of the unique things that happens with a hip fracture or a hip dislocation, I will kind of group those together because we don't really know that in the field. But you'll see it, if you look at x-ray, a lot of times it's where the femur comes up and makes the turn like into the pelvis. It kind of elbows out, and it's it'll break right there, right at the head. And that is extremely difficult, painful, and it needs surgery to fix. So a lot of times your elderly patients will get this. They fall, they land on their hip, their pelvis area, and it will break right there at the head, the ball of the femur. So it doesn't come out of place, but it breaks right there. And what that does is the leg is no longer stable. So you will see their foot actually rotate. And depending on which way the bone is facing, if you're laying down on the ground, typically your feet probably stick straight up in the air, typically.
Right.
And I will say normal, but you know what normal is. Nobody's normal.
Exactly.
But with these patients that have the hip or pelvis problem, their foot will be laid over at like a 90-degree angle. So it's perfect. Like your one foot is up in the air, like at 12 o'clock, and the other foot is pointing at 3 o'clock. And you're like, oh, bingo, we got a problem. We know where it's at. And sometimes you'll even see these shortened as well, because the body there again, it automatically starts splinting as best as can. So you'll see that foot get shorter, maybe like an inch or two. You'll see it just rotated and shortened. And then we can stabilize that because we don't know if it's a dislocation or a fracture, but we can take them to the hospital, get an x-ray. But we can do a pelvic binder, and they make some commercial pelvic binders. They're a little expensive, but you could make one out of a bed sheet. Just make it about 2 inches wide, slide it up under them, and then come across and just do a regular knot and kind of pull it tight to kind of help pull it in place and help stabilize it. If it's you could also use 2 tourniquets, like 2 cat tourniquets, 2 soft T's if you'd like to. Just hook them together and then use the windlasses to kind of help tight and pull pressure on that pelvis, the hip area, to kind of help hold them in place.
Yeah. And pelvic binders are actually a pretty effective thing. I was looking at a study the other day when I was looking through the show notes, and it said that the study group achieved statistically significantly improved survival and lower mean blood transfusion volume and mortality rate, although they were more severe in the trauma score. And then they say the recommendation from the report was recommend prompt pelvic binder use for suspected pelvic injury before definitive imaging is available, just as a C-spine collar is used to protect the cervical spine from further injury prior to definitive identification and characterization. So pelvic binders are important and
yes,
help with mortality.
They're getting more and more important. I would say the more we're learning about them, because when it hasn't been that long ago, just even a couple years ago, we didn't even know what pelvic binders were. Like, we're not really using that. And now I just took the recent update, 2019 update for PHTLS, which is the pre-hospital trauma life support class. And there was a whole section there just on pelvic binders. So anybody with suspected pelvis fracture, hip fracture, anything like that, you should be looking at putting a pelvic binder on them.
And do you need to place the leg in any specific way when you put that on, or is that outside the scope of our discussion here?
We'll talk about it in just a few minutes about making things look normal. If there is no pulse, but typically we're just going to leave it in a position of comfort.
Okay, got it. Sounds good. All right, so we're moving down from there to the femur, that big, huge bone in our leg.
Yeah, so this is the strongest bone in our body. And so there again, think about mechanism. If it broke the femur, think about how much energy it took to break it. And sometimes you will see that, energy is moving down the femur. So maybe it did get a pelvis, maybe it got a knee. Maybe it's just not an isolated injury, which is one of the things, we need to look at with this femur fracture. If you are doing your assessment and you see that it is a mid-shaft femur fracture, means that the fracture is obviously between the hip and the knee. We call that a mid-shaft femur fracture, pretty easy. And we pull traction on it, means that you grab the ankle and you pull on it. And it takes a lot of pressure to pull against this, but your patient will go from screaming bloody murder to how bad this hurts to, oh my gosh, don't let go of my leg. Because what's happened now is the femur, there's only one bone there. So you can pull traction on it. And when you do, the nerve endings that were touching each other that were very painful are now gapped. So it still is uncomfortable, but it no longer hurts them. So when you pull, you're pulling against the thigh muscle, you're pulling against all those muscles in the leg, but it takes the pain and almost completely takes it away. So we do splint that one a little bit differently. They make some commercial devices, which makes it a lot easier than trying to make one. But it's a traction splint device. It attaches to the pelvis in some way. There's multiples on the market, but they all attach to the pelvis as an anchor point. And then they have a rod or maybe two rods that come down the leg. And then they have another way of attaching to the ankle. And basically, you're just holding that leg stretched out as hard as you can stretch it until they get to the hospital.
Dang. So that take a lot of energy actually, right?
It does. I mean, because you're pulling against basically their entire leg muscles. So it does take a lot of energy. That's one of those commercial devices. Obviously they can be pricey, and I don't necessarily think that everyone needs to go out and buy a traction splint today. But that's what, when EMS gets there, they're going to put that on there. So for us as a civilian responder, you can assess the leg, know that it's an isolated injury. Because if it's anything else, like if maybe you have a femur fracture, you have a knee dislocation, then we don't pull traction, because you don't want to, because then you're going to pull the knee out of the socket even more.
Mm-hmm.
So as long as it's an isolated femur fracture, you can pull on their leg. And the moment you pull on the leg, they're going to feel relief. But if it's anything other than, if it's you think maybe their ankle's messed up too, we would not pull traction on. We're just going to splint it the best way we can, running some cardboard or maybe some kind of splints up, controlling the pelvis there again. Maybe a splint comes up along the outside of the leg to kind of help control the pelvis. Wrap it, secure it with triangle bandages, around the knees and things like that to kind of hold those board in place. But we would not pull traction on something that had multiple injuries going on with the same leg.
Makes sense. I was just looking. Have you heard of the Prometheus traction splint?
I don't think so.
It's $131, which is actually not bad at all.
Huh.
I'll look more. I'll send you the link so you can actually see it. But I was thinking maybe like 500-600. So it looks like there's a couple out there that are kind of in this neck of the woods. Doesn't seem too terrible.
No, like for me, I use the North American one a lot because it's compact.
Mm-hmm.
It has like Velcro straps go around, secure around the pelvis, and then it has looks like tent poles, like the tent poles you connect together. Like there's a string in there that kind of pull tight like a bungee cord.
Yep.
They snatch together. I can wrap more Velcro around the ankle, and it helps hold it in place. So it's a little pricey, but for me and what we're doing, like search and rescue, weight is a problem and size is a problem. I can't carry the entire ambulance, so we've opted to go with that one for doing stuff in the woods.
All right, I like it. Is that everything on femur?
I think so.
All right. What about lower legs?
So lower legs, we're going to treat those just like we did the lower arm area, like the radius ulna. Now we're dealing with a tib fib. So you can use boards, kind of the same thing. But there again, putting boards on around the ankle, behind the knee is important because you've got to be able to control those joints as well so they don't move. So I'll run a board that runs up under the heel to behind the knee and secure it. And I usually do on the side too, because sometimes you lose like how some side motion with those bones fractures like that. So I'll run three cardboard splints around, 2 on the side, 1 behind the knee, 1 behind the ankle, and help secure it in place. That way I have the ankle so it's supported and also have the knee so it's supported.
So generally exact same stuff. 2 bones down there and just, bigger bones, but generally same process.
Yep, exactly.
All right, I love it. So next you have written PMS, which as I understand it doesn't have anything to do with fractures.
Yeah, this is something, a little bit different than what we normally say PMS. And, you wouldn't want to tell your female patient you're going to check her PMS because she probably is going to slap you. She's going to be angry because she broke her leg and now you want to check her for PMS.
And then you'll get some of those distracting injuries yourself.
Exactly. And you go to court and it's a whole long process. But no, this stands for pulse motor sensory. So before you put a splint on or anything to help with this injury, you want to check to make sure they have a pulse there. And I believe it was the first episode, wasn't it? Or what episode did we go through checking pulses? You remember?
It was probably circulation or maybe even just a massive bleeding.
Maybe.
Yeah.
Either way, if you haven't listened to those episodes, you should go back. And if you've already listened to them, maybe go back and listen to them again.
Agreed.
But you can check a radial pulse. You can check a pulse on top of the foot, behind the ankle. But you want to make sure that they have a pulse there because they're still getting circulation past that injury. Make sure they can still move their fingers, move their toes, and then make sure that they can feel you touching the fingers, touching their toes, things like that. And then afterwards, after you put whatever splint you put on it, you want to recheck those because now you've created a tourniquet. You put the bandaging too tight, or you wrapped your splint just way too tight. Now you have a tourniquet on them, and that's not good either for this purpose. So before you treat them, check pulse motor sensory, and then afterwards check pulse motor sensory. And if you lose one of those, go back and take this splint off and kind of figure out what you did wrong or what's changed in the patient, and so you can regain all 3 of those functions back.
Okay, very well put. Now, there's tons of splints. We've actually talked just a little bit about some of them, but there are so many out there. How do you kind of navigate which ones are decent? Which ones do you use personally? And what's safe to buy?
Yeah, it depends on your budget. If you we deal sometimes with university, high schools, and they have a great budget. So they're running air splints and they're actually pretty cool. They go around the arm, around the leg, and they use either like a hand pump or a foot pump, and they blow air up around there and it helps hold it in place. It's a fantastic splint. It's just super expensive. So it's not in everybody's budget, everybody's wheelhouse for that. But you may see that, if you're at a ball game and a child gets injured, gets hurt, you may see the training staff or whoever come out, slide this device on top of their leg or top of their arm and inflate it, and that's a nice air splint. They work really well. And another one that's probably more common you'll see is like the SAM splints or the aluminum style splints. Everyone calls them SAM splints. But there are multiple companies out there that make those now. But they're aluminum splints. They're pretty flexible until you start bending it. The more bends you put into it, the stiffer, more rigid it becomes. So I love these types of splints because you can run them in your backpack. They're flat for the most part. There's some other styles too, but then you pull it out, you start bending it, molding it to what you need it to look like. Put it on the arm or leg. Use some co-band, use some tape, use some triangle bandages, whatever, secure it, and it helps hold it in place.
Yeah, I 100%. I love SAM splints because they're multi-purpose, and I love multi-purpose stuff. But yeah, they work well.
And then you could always be thinking about improvised medicine, maybe using a pillowcase, maybe using magazines, maybe you're using a piece of wood from the woods. You're hiking and you don't have any of this supplies, so always be creative with this. You don't want to cause any more harm to the patient, but be creative on how you're going to splint the injury.
Yeah, absolutely. All right. So that's pretty much the types that are out there. For civilian responders, which would you say you recommend most?
So I think look at the SAM splints. I mean, you can find them, generally between $10 to $20, depending on what it comes with, what device. You can get it in OD green to look all tactical. You can get it in bright orange, so people can see what's going on. But different ones out there. You can find them used typically too. I say used, not used. You don't want a used one. Yeah, you just wipe the blood off of it. It'll be fine.
Previously owned.
Yeah, previously owned. You can find some surplus ones that the military's getting rid of. They're at a gun show like that. You can find those pretty cheap. So I would absolutely pick those up, and you can put them in your vehicle. You can put them, in around your house, wherever you'd like them to. It's probably not something you can run in your plate carrier, but something you can have around, and they're very useful.
And really inexpensive too. Not bad at all considering all the other things we have to buy.
Exactly.
All right.
And we were talking about, the note checking for the pulse and things like that. So if you're doing an assessment and this foot or arm just looks really jacked up, and you're a long way from the hospital, because now it looks jacked up, it's rotated around, it looks nasty, like you're about to puke. And you check and you do not feel a pulse, and maybe it's discolored, it's got mottled, it looks kind of spotchy, the color doesn't look good in the arm or the leg. um, Understand that that person basically has a tourniquet on their leg, on their arm. So if you are a long way from the hospital, you're on the trail, you're that 2 to 4 hours out from the hospital, you're going to need to make this extremity look normal. Now, if you're at the supermarket and you're across the street from the hospital, don't worry about this. But if this is for someone who's, they're a long way from getting help, getting to the hospital, you may have to pull on it and make it look normal. So you pull traction on it, like we talked about with that femur, you kind of pull pressure on it, pull their wrist, pull their ankle, and you rotate it back to make it look normal.
All right. So that makes sense. So make it look normal if you're outside that 2 hours or so.
Yep. And the patient's not going to like you very much, but you may actually save their extremity from them losing their arm, losing their leg. This isn't very common, but it's just something we need to look at and pay attention to.
All right, makes sense. Man, I learned a lot there. That was a lot to digest. I'm literally going to go back. A lot of our episodes I go back and listen to personally just to kind of take notes on what I think was communicated well, but this one I'm going to be going back to just to take notes on. This is really good information.
Yeah, I mean, like the last few episodes, especially, I think we could go back and listen to those again and again because we talked about the medical. We covered a ton of subjects through that, and then last week we talked about building a trauma kit. So people, I think, obviously can go back and look at that as they're going through their finances situation change or whatever, they can build them. And then fractures are always something that is very common that we may actually run into.
Yeah, 100%. All right, so I think that's it for fractures. And next, we wanted to talk about TCCC updated guidelines on tourniquets. This is awesome. I've been reading so much about all this different stuff, and there's a really good articles, really good videos. In fact, one by Skinny Medic and yourself. But what surprised you about it?
Man, I really wasn't sure what was going to come out, be released. I knew I'm friends with a couple of the committee members, so I knew they were looking at stuff, but they were keeping pretty light, sealed lips. They weren't talking at all. But I knew they were looking at some stuff, and I thought maybe one of the tourniquets would get released, but then a couple of them came out. I was like, man, that really shocked me. But I'm super excited. Like, I love the technology moving forward and more tourniquets getting into the market. And I'm excited where we're at in trauma care right now.
Yeah, I am too. And there literally are just so many out there, and now so many that are recommended, which is pretty cool. It means that all of us as people who are interested in medical, civilian medics, actual medics, EMTs, paramedics, PJs, I mean, there's just so many more options out there now, and we should all become familiar with all of them because guess what? Now that they're out there, these companies are going to hit big, huge marketing campaigns, which I support and applaud. And there's going to be a lot of these on the market. So, if you come across one of them, if you ever need to use one of them, you should know how to use them all.
Exactly. And for those who guys are not familiar, the TCCC committee is a trauma group of really smart people, and they recommend items to the military to say, hey, look, we've done a lot of research, a lot of data to prove that these are effective. So if it doesn't pass their standards, then they will not recommend it. So they're doing a lot of research and a lot of data to stand behind them. So if they are putting their recommendation, their approval on these, then that's a big deal.
Yeah. Now, have they put out all the results of the testing? Because they said they were going to release the methodology and the results of testing for each one of them, or all the ones that they tested. Is that out yet, or is it just the list of recommended?
I believe it's just a list. I have not seen any more information out. I think it was just a list. So there again, I am looking forward to looking at more and more data on these and kind of seeing what went through.
Yeah. Was there any big surprising things that weren't on the list that you expected might be looked at least?
Not really. Not ones that I thought. I mean, there's a couple. Like there's another ratcheting one. This guy down in Florida. I thought maybe he is, but I don't know if he didn't get in there. I don't know the background information. But the ratcheting tourniquets honestly surprised me that they were on the list. You know, I've read some good stuff. I know some guys who approved them, but I was still kind of like, I don't really know. I was on the fence about them. But to see that they were approved, I was like, all right, let's do it then. So you know, I've never carried a ratcheting tourniquet. I know guys who do and who carry them every day. But you know, I never carried one, so to see them get approved, that was interesting.
Yeah, I've never actually even used one, so it was totally new to me.
I know a lot of guys who like them around water, because you know the Velcro, maybe the soft teat as well, don't do so much well when they get wet, salt, mud, stuff like that. So a lot of guys who are into like surfing, diving, things like that, have really gotten on board with these ratcheting tourniquets. So I think that's kind of where they're getting their big push from. So I'm excited. I've got a couple of them that I'm going to play with and do some reviews on, but I'm excited for them.
Epic, man. Can't wait to read the details. I'm really excited about it.
Yeah, I think it's going to be some good stuff.
Yeah, me too. All right, so product of the week, I guess, is very fitting since we talked about fractures. What is it?
Yeah, so this is a product that we carry at Medical Gear Outfitters. This is the Dynarex version of the SAM splint. It's called the AccuSplint, and we've got different versions in stock. We have a finger splint. This is a small metal aluminum splint that you can mold around the finger. Then we have a flat version that's great as well because you can kind of put it in your backpack and it's easy to stow away. And then we also have one that's a rolled version, and I like it. It's a little more it takes a little more real estate in your first aid kit, but it's round, and then in the middle of it has your Sensi wrap, so your co-band. So everything you need to apply that splint is already in one package. So it takes up a little more real estate in your kit, but you do have everything you need in one package. So you can apply it, use the co-band, it sticks on top of itself, and you can secure the splint.
Which is pretty dang handy. And I was looking on the website and saw all those. Links will be in the show notes along with that discount code Civilian Medical for 10% off your order. And I think that'll do it for the show today. Lots and lots of stuff to digest and good stuff, man. Thank you.
Yeah, like I said, I appreciate the guys who are supporting us, who are downloading, listening to the podcast. I love getting feedback from you guys. I appreciate the guys who are going to Medical Gear Outfitters and buying from us. That coupon code is getting used, so I appreciate it.
Epic stuff. So get some medical training if you're out there. Go check out medicalgearoutfitters.com. Don't forget code Civilian Medical saves you 10% off your order. And that's for all the great stuff that we talk about on this show and just so much more that we haven't even touched on yet that we will in later episodes. So thanks for listening. And Skinny Medic, I will talk to you next week.
Yes, sir.
Find us and subscribe at civmedical.com.